Hi, everyone, and welcome. Thank you for tuning in to today's webinar on Florida's new minimum wage requirements for Medicaid providers. My name is Nancy Patton. I'll be your moderator for today to help with any connection issues and help address questions at the end of the webinar. We're very happy to have you here with us, and there's a lot of information to cover. So before we get started, I have a few housekeeping notes to mention. First, everyone on the line has been muted to limit any disruptions. If you have questions, we encourage you to share them with us using that Q&A feature in your GoToWebinar control panel. If we have time at the end of the webinar, we'll answer those questions, and if not, we will follow up with you on your questions after the webinar as well. Our webinar is being recorded, and you'll receive a link to watch it within 48 hours along with a copy of the slide deck. So make sure to check your spam or junk email folders in case that email gets caught in there. Immediately following this webinar, you'll be prompted to complete a very short survey. We'd love to hear your feedback on our webinar and any other topics related to healthcare industry that you would like us to cover in the future. Our speakers today, we have Saltmarsh shareholder Andrew Kent. He is our healthcare practice leader based out of Tampa, Florida, and he is joined by Susan St. John, a partner at Garfunkel Wild. She has over 30 years of healthcare industry experience, and they're both eager to get started and shed some light on this new rule that's coming up. So Andrew, I'm going to turn it right over to you.
Excellent. Thank you, Nancy, and welcome everybody to the webinar this afternoon. We appreciate everybody taking some time to join us today. So we're going to be talking today about an overview of the new Medicaid minimum wage requirement. We're going to be talking about which types of providers are impacted by the new rule, how reimbursements are expected to be impacted, what steps providers will need to take to be compliant, and what the penalties are going to be for non-compliance. And then, like Nancy said, we're going to have an open line for Q&A. If we don't get to all the Q&A today, Susan and I will be following up with all our attendees after the event. And so to kick us off and to introduce Susan St. John, Susan, I'm going to turn it over to you.
Thank you, Andrew. I appreciate that. As we all know, Governor DeSantis signed into law a Medicaid minimum wage rule. The money's being appropriated through General Appropriations Act. It comes from many different buckets, but is specific to help the providers and the Medicaid payment system, including managed care, fund the required increase in minimum wage for direct care employees, or independent contractors. So as you can see on your screen, it includes approximately $600 million in new funding that's going to be sent to the Agency for Healthcare Administration. And of course, that's for the sole purpose of increasing the minimum wage, but it's also for the purpose of being able to fund the providers who have to increase minimum wage so that they'll be able to deflect some of those costs. So what that means is your rates are going to be increasing for fee-for-service, and your capitated rates are also supposed to be increasing from your Medicaid managed care providers. As I mentioned a minute ago, the rule covers your W-2 employees, and it also covers your 1099 independent contractors. So for anybody who's thinking, oh, it says employees, and inherently we think of someone that is a W-2 employee. We don't always think of 1099 independent contractors, but the law has been specific to include both. So if you have folks who are not being paid $15 an hour now that are direct care workers, whether they're W-2 or 1099, that's what this law is going to be changing. The new rule impacts the majority of Medicaid providers. And including, as I said before, those that are fee-for-service and those that bill Medicaid managed care.
And Susan, this is independent from the $15 minimum wage requirement that was going to be phased in over 5 years that was passed back in 2019, correct? This is a completely separate minimum wage requirement for healthcare providers only.
Exactly. I mean, I think by 2026, we would have had our minimum wage across Florida is going to be $15 an hour for our Medicaid providers. That's now been accelerated for direct care workers. And there's a little twist to that, which we're going to discuss as we work through these slides.
Absolutely. Excellent. So then a lot of folks are asking what providers are impacted. And so AHCA has published a list of the specific fee for service schedules that are being impacted. And so that's how they're delineating who's getting impacted and who's not getting impacted. So if you bill the program, if you bill Medicaid under one of the specifically identified Medicaid fee-for-service schedules, then you're going to be subject to the requirement. And so as you see, the list is pretty extensive. It includes, behavioral health overlay services, dental fee schedules, hearing service fee schedules, skilled nursing, ICF IDD providers. So it's a wide range of providers in the state who are going to be impacted by this new minimum wage requirement. There are also, though, a group of providers who are not going to be subject to this requirement. And we'll talk about those on the next slide. Susan, you want to go through these?
Yeah, one of the things I want to, the providers who are exempt, I was going to mention on the providers who are not exempt, within your associations, really have some interactive conversation about how you're impacted, and keep those communications open, because you're going to want to compile some data, and we're going to talk about that in a little bit.
Absolutely.
Okay.
Absolutely.
The providers that are exempt, as you see here, again, this is from ACA's website, and there are a lot of folks that are exempt from this minimum wage requirement, like behavioral analysis. So we see a lot of BCBA entities that provide certain types of therapies and behavioral services to populations, generally young children, and they're not going to be impacted by this minimum wage. So that, so they're kind of off the hook. And I think that's good for that industry. But there, then there's some other industries that are off the hook for this. And they're usually ones that the services are not quite as intense, or the folks that are rendering the services need minimal education. So it's a little bit different there. But that's what I'm looking at when I'm seeing who's exempt. It's the type of services they're providing, and the fact that they can use a lot of non-skilled laborers to provide those services.
It is, though, Susan, it's correct that it's only, you're only exempt if you bill exclusively under one of these schedules. If you cross over into some of the schedules that are included, then you're going to be subject to the minimum wage requirement.
That's correct. Exactly. So if you fit one of these exemptions, but you're also, you also provide services that are under a provider that's not exempt. So if you have a duality, you are non-exempt all the way around, even if part of what you do would have been exempt.
Excellent. And then the Medicaid managed care plan. Susan, you want to take us through this one?
Yeah, so they're gonna, the Medicaid managed care plans are supposed to amend their contracts with the Medicaid providers so that the Medicaid providers will see a rate increase. We realize that getting a managed care plan to come to the table to amend a contract is usually a very big lift. But here the government has mandated that they have to amend their contracts. So the hope is that they will actually be timely with doing this and they will get it done. They also, again, it's also so that it has enough increase to meet the increased cost to the Medicaid providers. So we're hopeful that Medicaid managed care programs will really step up to the plate and get this done relatively quickly. There's some specific dates on when they have to have this done, and we're going to talk about that in a couple of slides.
We do know, though, that this is a big issue right now because there are large classes of providers who have not received updated rate schedules and not received new contracts from the managed care plans. And so we know a lot of providers out there are kind of in limbo waiting to see what their new payments are going to be, right, Susan?
This is correct. And the managed care plans do have a time frame that they have to have this accomplished by, but they've got a little flexibility in getting it accomplished. It's just that for the fee for, and we're going to talk about this in the a couple of slides, but the fee for schedule folks, there's going to be some retroactive application, but the managed care plans, there's not going to be retroactive application. It's going to be prospective, but should be prospective from October 1. So that's something to keep in mind too. And again, when I was speaking a minute ago about staying in communication with your associations and keeping those conversations open and keeping records of how much you're expending, how much additional increase in cost you've incurred because you're meeting this $15 minimum wage requirement. And as you'll see, as we'll talk about it again, it's not just that you're increasing by $15. You have everything that is, if it's a W-2 employee, you have everything that goes with that, the employer side taxes and so on and so forth. You need to be keeping records of all of that and comparing from this time last year to this time this year when this takes effect, what the difference in cost is, and then comparing what the difference in reimbursement is, really at the same service level, not that now doing more expensive services or less expensive services. You want to make it as much apples to apples as you can, because that's something that the governor, the legislature, and ACA need to know is, while this is supposed to be a positive thing to strengthen the healthcare workforce that has been so stressed from lack of persons, the other side is, we need the government officials to understand that this may be a huge stressor to providers when they do the analysis and look at and compare from prior year to current year once this law takes effect.
Absolutely. All right, excellent. So what does the new rule require? So providers participating in one of the identified Medicaid fee-for-service schedules must pay all direct care workers at least $15 per hour by October 1st of 2022. We're going to talk about that definition of direct care workers and talk about one very important exemption to that here in just a minute. But obviously that's a big question mark, because what falls under the bucket of a direct care worker is going to be very crucial to this process going forward. Direct care workers are defined as an individual that has direct contact with a Medicaid recipient for purposes of providing a Medicaid reimbursable service. They do not include individuals whose primary duty is maintaining the physical environment of the workplace, or whose duties are primarily administrative. So, that would seem to exclude folks like your maintenance and janitorial staff. It would seem to, exclude folks like your back office or, accounting personnel. The question obviously becomes, in this current modern world, especially with staffing issues, I can't tell you how many providers and how many clients I've spoken to over the last 2 years who have had, accounting folks delivering meals to rooms because of COVID lockdowns, or, other kind of blending of duties and responsibilities because of the need in the marketplace or the inability to fill shifts. And so, there's going to be some questions around who is or is not a direct care, a direct care employee. And there's still some gray area here because it's not, it's not really well defined. The ACA has given us some examples of direct care workers, though. And Susan, do you want to walk through some of the examples that they've given us?
Sure. Also, so on this next slide, you'll see some of the examples of direct care workers. Social workers, nurses, of course, LPNs, home health aides, certified nurse assistants, physicians, dietary technicians, so registered dietitians, you can expect to see that as well, surgical technologists. One of the things you can pick up from this list is that these are workers that are providing services that ultimately find their way, the composite of services find their way into a Medicaid bill. And so so that's what Andrew was talking about on the prior slide, is there going to be some people that do not fit into this, like your janitorial staff, maybe your security if you're a hospital or a facility. They won't be direct care workers, because what they do is not directly related to the patient care. So you have to think about that. You're going to have, if you're a hospital with a cafeteria and you have food service staff that man just the cafeteria, that doesn't make its way into a service to our patients. So those people would be exempt. So it's really important to delineate and kind of make dichotomies of your employees, and remember, this also includes 1099 employees, and see what buckets they fall in. So you can ascertain, is this something that makes its way to a Medicaid bill or not? So those are important things also to start addressing and managing now, because you're going to need that when you're running analytics on how this new law is going to impact you overall. So
it may be helpful,
so,
Susan,
yeah.
for example, to make sure that your position descriptions, your job descriptions are updated, and that you're identifying who is and who isn't, who does and who does fall into these buckets, right?
Correct.
So, yeah.
I think that's very important. So again, this list is a good start. And as Andrew was talking about a minute ago, we know in smaller providers in particular that we see employees in two functions and dual roles. Like sometimes in our home health agencies, while they may be in a role of predominantly administrative staff, but then they also, they might be a home health aide, they might be a CNA that can and they had, decided they wanted to be in the administrative side. They're good at that. That's what the HHA understands, that's a good role for them. But in a jam, they might be asked to go provide patient care. So if they're being paid, let's say $12 an hour because of their position in the administrative office, they start giving patient care, they're crossing over, you're now looking at paying them $15 an hour. We had the question come up of, if they're in this role, can we pay them the fee, the amount we were paying them of $12 an hour, and when they provide services, can we pay them $15 an hour? It's a really good question, because it's not really answered in the literature that is out there on this bill. I think that's a possibility, but you have to look at the administrative gymnastics you're going to have to do to toggle someone's hourly wage back and forth. And they'll have to have two different, if you're using job codes, you're going to have two different job codes. They have to keep diligent records on when they were in the administrative office and when they did any type of patient care. So those are things you have to look at and then weigh whether or not this is something you want to undertake or not, or is it in the long run more cost effective to keep that person just in the administrative office and then get a part-time or PRN staff level or direct care worker to go and provide care as needed when you have a higher census, or when you have somebody who's on vacation or calls out because they're sick for the day or some other thing. So that's something that you have to be really careful of, because if you have someone switching back and forth and you don't keep records, I can tell you that AHCA is going to default to the $15 an hour, and that worker may think that too, and you don't want to end up down that road, which we're going to talk about in a few minutes.
And unfortunately, these type of administrative burdens are going to be most acute on the smallest providers, where you may have these kind of job sharing and dual role issues are most prominent. So, just something to be aware of as you move forward through this. So
right. I want to add one more thing. When we were talking about W-2 versus 1099, sometimes, because when they're W-2, you're going to get all the employer side expenses for the increase in the minimum wage. And when they're 1099, you're not going to get that increase. You're going to get just the wage increase. For a lot of healthcare providers and for a lot of the staff that are going to have to be increased, if you switch them from a W-2 to a 1099, you're going to raise a red flag with Department of Labor. And also, Department of Labor does not like you misclassifying individuals as 1099 when you have control over them, and they really don't have, they don't have a say on when they go to work, who they have to see as a patient, and so on and so forth. So those are things that we want you to be thinking about, because we know there are some people who have asked, well, can I just reclassify these folks as 1099? One, it raises a red flag. Two, it probably is a misclassification under Department of Labor laws, and those are federal laws, and those those have even more teeth than what we're seeing here. And you don't want to go down that road. But if you have a question on it, please feel free to ask us.
That's a great point. All the old rules that we've been living with for some time concerning, you know, who qualifies as a 1099, who qualifies as W-2, they're all going to still apply here. You've got to make sure any changes you make in your staffing model continue to comply with the rest of those regulations. So nursing homes this is one of those kind of major changes or major kind of carve outs here in the law. As we've been talking about, for all the other providers, it's the law, the minimum wage requirement applies only to the direct care employees. And so obviously you've got this discussion about who's a direct care employee, who's not, who qualifies. For nursing homes, it's simpler. It's simply everyone in the provider. So the law is very specific. It was actually carved out in the legislation. The language is different for nursing home providers, but all employees of nursing homes must be paid at least $15 an hour by October 1st, 2022. And there's no distinction in the new law between direct care and non-direct or indirect employees or admin employees or any other classifications. So everyone from your security to your front desk clerk to your maintenance folks, your back office admin, your dietary, they are all subject to the new rule. They are all going to have to be at $15 an hour by October 1st. And Susan, anything else you want to add here?
Yes, one of the things that Andrew and I talked about quite a bit, and when we were creating the slides, nursing homes includes skilled nursing facilities and non-skilled nursing facilities. So we typically see more Medicaid patients in the non-skilled nursing facilities that are, you know, the basic room and board. The people are not post-acute. They don't need post-acute care, but they need some care and they need more help than they would get at an assisted living facility with managing life and somebody taking care of them. But it does include both, and we want folks to realize that so that you can plan accordingly.
Absolutely. So Susan, you want to take us through some of the other potential provider challenges that we anticipate with the new rule?
Yes, I sure do. So a question has come up specific for our hospice providers because they're struggling with who all is going to be included under direct care worker. So again, it goes back to how is the bill going out, what services are being rendered, and who all contributes to the services that ultimately get billed to Medicaid. And so with hospice, we know they use interdisciplinary teams of a lot of different folks, social workers and physicians, nurses, LPNs, aides, assistants, companions, and all of those things are built into a per diem rate depending on what level of service that hospice provider or hospice patient needs. And so when you're looking at that, you really have to look at that holistically and how the patient is being cared for. So for a hospice patient that's receiving hospice at their residence, whether their residence is their home, their own residence, or a nursing home or an ALF, you know that you're not going to be sending anybody else in there except for care. So all those folks that go in for care, you have pastoral services that are part of the interdisciplinary care team. All those folks that make up who's providing services under the interdisciplinary care team, those are subject to this $15 minimum wage. At least that's our understanding right now. And I think even ACA is struggling with that because when the legislature promulgated this rule, there was a lot of thought that was put into it, but there's a lot of things that some folks don't quite perceive. And this is one of them. When you have a care plan with multiple facets and multiple folks involved in it, and you're getting a per diem. In other words, unlike home health, where you're billing for the service, the RN service, the LPN service, the aide service, this is a per diem based on where you're at, your cost report that you submitted, and a lot of other factors that go into making those separate for rates of either routine, continuous care, respite care, or inpatient care. And so you have to look at all of that. So we encourage you to ask questions on that. And again, make that dichotomy of who all goes into an interdisciplinary care team so that you know who may need to be increased to that $15 minimum wage. Assisted living providers, we have many that receive funding through the Medicaid managed care long-term care plan, either through Medicaid managed care or long-term care plans, and they've been asking questions. Some of them, such as, there's a person that has to be there 24/7, and the person who's there at night, especially in our small ALFs, most of the time they're asleep. And so how do you carve that out? And again, it depends on how you're billing. If you're billing for certain services being provided, then it's easier to determine who the direct care worker is. If you're billing for per diem, then it's a little bit harder, because who all went into taking care of that patient? That nighttime person, they certainly went into helping take care of that patient. So there's a likelihood that you're going to see they have to be $15 an hour as well. So those are the things we want you guys to track and keep in compare to last year and how you were reimbursed, and what this new law is going to do for you, because those are going to be important follow-up discussions with the legislatures, and especially in this next legislative session that's coming up.
Absolutely.
Okay.
Absolutely. So good discussion there. So impacts to reimbursement. We know that providers are going to be reimbursed for their increased expenses through the Medicare fee-for-service schedules or the Medicaid managed care plan. So, we're expecting to see reimbursement rates increase. ACA is pledged and actually required to have all Medicaid fee-for-service schedules updated by October 1st. Most of us looking at the calendar realizing October 1st is just a couple of weeks away. Now, as of yesterday, ACA had only updated the following schedules: so the hospital and ASC inpatient and outpatient services fee-for-service rates, and the ICF IID fee-for-service rate schedules. So there's, if you remember, that list of impacted fee-for-service schedules is pretty long. We know there's a lot of unknown right now with regards to final rates. And so, the industry's in kind of a wait and see right now as we wait for ACA to go through the rate analysis and publish the revised rate schedules. It's obviously a critical issue for providers who are trying to budget what this is going to cost them, and who are looking at having to be compliant on October 1st with money that they don't know what it's going to be, and B, they haven't received it yet. It is important to recognize that rates for nursing homes, federally qualified health centers, and rural health clinics are all going to be effective on October 1st. So those rates will become effective for billings as of October 1st. All the other Medicaid fee-for-service schedules will be published ostensibly by October 1st, but will be retroactive to July 1st. So we do expect that, for billings that you've already completed and possibly been paid on, there's going to be some updating and, going to be some additional reimbursement for some of that billing, which is going to be important for providers as they work on getting compliant here. So Susan, and other thoughts on the reimbursement impacts?
Right. I mean, I think you've covered really 95% of it. We do expect to see some. We do expect providers will get remittance advices that have applied the dates retroactively, so you'll be getting additional money for claims that were July 1st and forward on the fee-for-service, and we anticipate that there'll be specific explanation on your remittance advice or the payments that you receive. And you want to make sure that you track that and compare it to what you've billed and what the new rate schedule is once they're published and you have hold of it, so that you can make sure you've got your reimbursement. Those are really important things, because while the minimum wage is has to be in compliance by October 1, getting that little catch up may give you some bit of a cushion, not, well, I would say a cushion, but give you a little bit of hope of being able to have something that helps you defray these costs, because you have to be in compliance by October 1 with the rate of pay, fee for service, except for the four that Andrew identified, are retro to July 1. So there's a possibility that you will get a little bit of money to help you cover some of those costs even more than the money that you would have gotten if it started on October 1. So for those folks, there's a little bit of leeway for you, but you need to keep close eyes on that and compare it and make sure you're getting your money.
I'll note that, obviously this is a big concern for all providers because, everybody that's been a provider and has billed the Medicaid program know that, what the legislature gives, the legislature can take away. And, this is a little bit different because they're mandating this minimum wage requirement. We do note that on the ICF IDD fee-for-service rate schedules that I reviewed, ACA is providing a specific line item for the increase to the rate that is related to the minimum wage requirement. It'll be interesting to see how the other rate schedules are amended and whether that specific dollar amount. But to the extent that you have that ability to go back and compare, and we're going to talk about this in a few minutes, we are certainly recommending providers kind of track what that additional reimbursement amount is and then what your additional costs are, because I do think that feedback is ultimately going to be very important here. Susan, anything on this before we go to the attestation requirements?
No, I think we can move on.
You want to take us through the attestation?
So as all of you have been made aware that you have to, if you're a current enrolled Medicaid provider, and this new law applies to you. And remember, if you're on the exempt list, it doesn't apply to you. But as you saw, it'll apply to most everybody. So you've probably already been notified that you need to sign a supplemental wage agreement. Many of you have already signed the supplemental wage agreement. That's an attestation that you will be in compliance with your direct care workers being paid $15 an hour at a minimum. So that's an important thing. If you have not been noticed yet, go to your portal, your specific provider portal for Medicaid, and you should be able to download or sign online that attestation supplemental wage agreement. And so, right, so that's the easiest thing to do is find it on your portal. Most of our providers have been noticed, and a lot of them have already done that. And then if you enroll after October 1, if you guys are on here thinking I might want to be a Medicaid provider, and you are planning on enrolling, maybe you're a new entrant into a market, you'll be required to sign the wage agreement as part of your enrollment package. So that's we've had a lot of people ask us about that, and we have a lot more to say about this when it comes to some of the civil penalties that you might face if you haven't signed this agreement or don't comply with it.
So great summary. And so one thing I'll point out here is that and a lot of providers have been talking about this and asking questions about this. If you've gone in and signed your supplemental wage agreement, or if you've gone in and looked at it and had questions, you'll notice that the original ACA, the original language basically is you're attesting that your employees, and the actual attestation uses some kind of very I will say vague or kind of generic language about
fraud.
Yeah, employees up to minimum wage requirement. And ACA's response to that is, well, we're going, and apparently they have clarified some language here in the last week or so that to basically say it's only those employees that are impacted by the legislation or by the budget requirement. So, what ACA is saying is that even though you're attesting that you will have all impacted employees to $15 an hour, they're saying, well, wait a minute, provider, don't be worried about it. We only mean the employees who are subject to the law, even though they don't actually break that out in the attestation. So the attestation is confusing has been confusing for a lot of providers. ACA has tried to remedy that by adding the clarifying language that is only those employees who are impacted by the law. But once again, I think this goes back to this kind of vague definition of direct care workers. ACA's kind of unwillingness to put too much language into the attestation itself. They're trying to be compliant with the way that the law is written. The law is written in a somewhat vague fashion, and so this has been ACA's response, is that, yes, we know what it says. We're going to add the clarifying language. What the clarifying language means is that you're only attesting to bring those employees who are subject to the law up to the $15 an hour requirement. It's still going to be, there's clearly going to be some interpretation going forward as to who fits in that direct tier bucket and who the law applies to, right, Susan?
Yes, correct. And remember, when you're making that attestation, employees is beyond W-2. It's also your 1099s. So if you have any questions about that, please let us know. But also, again, this is where analytics is going to be very important for you guys to see how this is impacting you and compare it to prior year to know what the increases is really doing to your bottom line and what it does to you as far as other impacts, which we're going to talk about in a little bit.
Yep. Excellent. So penalties for non-compliance. So very interesting. The only direct penalty that the state has, that ACA has discussed is that providers who fail to complete the supplemental wage agreement by October 1st, 2022, and who are not compliant may be subject to recoupment of funds associated with the $15 an hour wage increase. So essentially, what ACA is telling you is if you're a Medicaid provider and you don't complete the supplemental wage agreement and you are non-compliant, whatever that rate increase that they're publishing that is associated with the $15 an hour minimum wage adjustment, that is going to be subject to recoupment. So, we've had lots of providers ask, can I simply not sign the supplemental wage agreement and not participate? ACA has made it very clear that they expect all providers to sign, and that if you don't sign, you're going to be subject to potential recoupment of funds. You're also going to be subject, however, to a new civil cause of action. And so this is, once again, very interesting. ACA's, their stated mechanism for enforcement is this, the supplemental wage agreement for existing providers and the potential recoupment of funds. But the law also creates a new civil cause of action that is going to become, potentially the primary enforcement mechanism here for this new law. So, Susan, before we go on to that, any other comments on the recoupment or for non-compliance?
No, the only other thing that pops into my mind, if you're non-compliant with this law, you haven't signed the supplemental wage agreement, so that means you're out of compliance, but you're still, submitting claims to Medicaid. I think they might have a False Claims Act against you. So I think even though they're saying we're going to recoup that money, what we don't see written here is you're not exempt from a false claims allegation from the Florida OIG. So I think you have to be really careful here that if you think, well, I'm just not going to do that, you are going to get the rate increase because that's going to be across the board. They're not going to go and administratively look and see whether you signed the agreement or not. It's going to be presumed that you did. So then you have to realize if you're out of compliance with the law and you file a claim, that's potentially another civil monetary penalty. You have other complications from doing that. So we want everyone to understand that while what we see in this law seems like, okay, that's set forth, we see it, that's what will happen to us. They'll just take the money back. Other side of that coin is you knew you were going to be out of compliance, you submitted a claim anyway, and that may be determined to be a false claim. You do not want to end up in that bucket.
Absolutely not. So, Susan, you want to take us through this new civil litigation risk? That's
yes, thank you. So like we were saying a minute ago, there's some consequences from non-compliance on the payer side. The ACA is going to take your money back, but then they could get the OIG involved. You might have a False Claims Act, but you also face this new statutory cause of action. And so what the new statutory cause of action does is it allows one of your employees, remember that's W-2 or 1099, to bring a case against you in a court of competent jurisdiction. That means usually where you're located. And depending on the amount they're suing to recover, will tell you whether you're in county court or circuit court. So they can bring this action to get their unpaid wages. In other words, you decided to keep paying them $12 an hour. You should have been paying them $15 an hour. And maybe this person worked 20 hours a week from October 1 through December 31, and they've now reported you, and they start this action against you, and you're going to have to pay them that money. On top of that, you're going to have liquidated damages equal to the amount you owe them for not paying them the $15 mandatory minimum wage. You'll also have to pay their reasonable attorney's fees and costs. And sometimes we realize the reasonable attorney's fees and costs may end up being more than you have to pay the employee, again, W-2 or 1099. The good thing here that Andrew and I had been discussing and noticed, because we know that some of our clients are really stressed, some of the providers are really stressed about trying to meet the October 1 requirement or deadline to be able to pay their folks this $15 an hour. And it might be quite a heavy lift monetarily. It might be hard with the current cash flow that they have going on. So we think just like when you raise somebody's rate of pay, and it takes a while for it to go into effect. It has to work through the payroll system, and it gets put into effect, and then it's retroactive to the date that it became effective. So the employee may get a couple of paychecks that are still at their rate of pay they were at prior to the $15 an hour, but then they're going to end up getting a paycheck that brings them in compliance, brings them up to $15 an hour as of October 1. We think that type of strategy will help the providers a little bit, and hopefully they'll start seeing some of that increase in reimbursement, so their cash flow is going up kind of close in line with when they're having to incur these additional fees for increasing the minimum wage for the direct care workers, again, W-2 or 1099. So we think that may give people a little bit of time. The thing is, you have to have it all cleaned up and the employee paid by the end of the year, by December 31.
Yeah,
I was gonna say, so
yeah, go ahead.
If you haven't done that and gotten the employee caught up, then starting January 1, that employee has the ability to bring a lawsuit against you. And, then you're going to have to pay liquidated damages. So make sure, if you're going to do that strategy, just like when you give someone a normal pay increase and it may have a time lag, but it's retro to the effective date, make sure that you have all of that retro pay to the employee no later than December 31. It goes on their W-2, it goes on their 1099 that you're reporting to the IRS. And if you have all of that done come January 1, that employer doesn't have a cause of action against you because you've actually complied. It just took time to get it worked through the system.
I think all those are just great points, because we're hearing lots of providers who are very concerned about, they've got this requirement that goes into place, goes into effect October 1st. They don't have their rate schedules yet. They don't have any of their retroactive pay yet. How are, and for especially a lot of our, extremely labor, almost all the healthcare providers on this call are probably labor is one of your primary, if not the primary cost. And so, that is a real stress. I think, there may be, because this civil litigation mechanism does not become effective until January 1, you may have a little window in order to get compliant and get your compensation actually paid, to, matching to your cash flow from the state, from the program. I would say this is something that you should be discussing with your accounting, team, your outside CPA, your payroll company, your legal counsel. If you're facing a true, real cash flow crunch, definitely get your team involved in this, there may be some strategies, and you may have a little bit of window here to get compliant prior to this civil litigation penalty. I also just want to emphasize, Susan, your comment about, that the unpaid wages on an individual employee wage, may not seem like a whole lot, right? I mean, it's, if you have an employee that works 2,000 hours a year and they were making 13 and they need to be at, 15, that's $2 an hour times 2,000 hours, that's $4,000. It's not individually a huge amount of money. And even with the liquidated damages, it's not a huge amount of money per employee, but the law specifically provides for reasonable attorney's fees and costs. And, that can add up very quickly, and it can certainly add up very quickly if you've got a payroll register that's got, 50 or 60 or 100 or 200 or 300 employees on it. Those numbers can get very big very quickly. So, getting compliant with this, and, the only other comment is just, it's very interesting to me here that, essentially this statute, the way the statute's written, it's essentially farming out the compliance obligation to the litigation counsel. I mean, Susan, I don't know if you have any comments on that, but it's just very interesting that the enforcement mechanism here is not inside ACA other than recoupment. It's really with the trial bar.
Right. I mean, I think that's correct. I mean, as far as, enforcing how much you're paying the employees, I think it has been kicked to the trial bar. I think when it comes to enforcement against the provider for billing and saying, well, you've got this additional rate, we're going to take it back. I think the enforcement there is the recoupment of monies paid and the possibility of a False Claims Act. So I also wanted to add, when you're implementing the $15 an hour for the employees that need to be brought up to $15 an hour, and that there's going to be a bit of a time lag just because it has to work through the payroll system, you want to be really transparent with the employees, because that's where folks get into trouble, when they're silent to the employee as to when they're going to see this money. You want to make sure they understand that it will be effective October 1, and that it takes time to work through your payroll system. Sometimes as much as 6 weeks. It depends on the payroll system you use and how much has to go into making that change and getting everything reset for how much has to be withheld. There's a whole lot of stuff that goes into that, but you do want to make sure that your employee knows it will be retro to October 1. And you also want them to understand that if they're W-2s, there's going to be withholding out of that pay. It's not going to be, oh, look, here's my hours. I worked 20 hours, got paid $13 an hour for 20 hours. I have $2 an hour more coming to me. They have withholding obligations that are coming out of that, their own federal tax withholding, and then their share of the FICA and the Medicare. So you want to make sure you have transparency, because those are the things that will keep you out of the courtroom. it will. And then if they have questions about when the pay kicked in and they got that check that had, a bit more money in it, that encourage them to come and ask questions, because again, you don't want to cause discord with your workers, because that's when they have discord, is when they're apt to say, well, I'm going to bring this up. I don't think I've been paid correctly. And they know, promise you, the employees know that this law, that they can start bringing lawsuits January 1. So transparency here is very important.
Yeah, and that segues nicely into this recommended best practices. So as Susan's talking about, make sure you document your pay increases. There should probably be a pay increase letter in every employee's file, noting the pay increase, noting the reason for the pay increase. We're certainly recommending that providers track their increased payroll costs, monitor increased costs across all employee classes, this wage creep issue. We all know that if you've been paying a CNA or a home health aide $12 or $13 an hour, bringing them to $15 an hour doesn't just impact them. It's going to impact everybody in the food chain above them. So your LPNs, your nurses, your other staff members who are receiving, $5 or $6 or $7 more than The $12 an hour are going to now expect $5 or $6 or $7 more than the $15 an hour. So, we're expecting providers to see, wages increase across the board. And then, make sure you track those increased payroll costs against reimbursement, provide feedback to your trade organizations, to ACA, to your legislative representatives. We've had a number of clients, Susan, or at least I've had several clients ask about, well, should I just drop out of Medicaid?
Me too.
Is that the practice? Is that what I should be doing? And, ultimately my comment to them is going to be, at the end of the day, we're all going to be working in a world, and all of our provider clients are going to be working in a world where, even if you drop out of Medicaid, you're still going to be competing against providers who are still enrolled, participants in the Medicaid program who are having to pay $15 an hour. And so, I think the world of a $12 an hour CNA is just simply not going to be there anymore. And, honestly, for many providers, that world is already, come and gone. A lot of providers are already at $15 or approaching $15 an hour just because of the current labor environment. Susan, any other thoughts or comments there?
Right. Well, one of the thoughts is for some providers, they can't disenroll from Medicaid because it's might be part of a certificate of need requirement that they had when they, had to apply for that and then get licensed. So we know, like nursing homes, there's some requirements when you're looking at, applying for a certificate of need, which ultimately leads to licensing if you win the certificate of need. And we know most of the time we see that providers that have had those requirements have committed to so much percent of gross revenues will be Medicaid and charity care. So you have to think about that as well. They can't get out. So the best thing they can do is to really look at their overall costs and start, and I know they run analytics all the time, but really this one is going to be really important for what they're seeing and how it impacts them. And then, I agree with everything you've said here about tracking payroll and looking to see, and then, should you consider dropping out of the Medicaid program? I 100% agree that these pool of personnel in your community will know who is paying $15 an hour and who is not paying $15 an hour. You may have a much harder time recruiting and retaining the staffing that you need that are CNAs and home health aides or others that fall into that direct care worker bucket.
Yeah, absolutely. So Susan, we do have a few questions, and we're approaching the hour. We're gonna have a couple of minutes, I think, to address some questions. We do have one more slide, so some key dates, a couple more slides here, and Susan, I can touch on these very quickly. Key dates, this is just, keep in mind, you've got several key dates. So July 1st, remember that's all impacted fee schedules other than skilled nursing, federally qualified health centers and rural health clinics become retroactively effective. So, be paying attention to your billing, pay attention to, bills generated for services provided after July 1st. You should ultimately expect to see some retroactive payments for those bills back to July 1st. October 1st, everybody has to have your supplemental wage agreements completed in the Medicaid provider portal. You don't want to not have those completed because you don't want to have your Medicaid payments subject to any recoupment. All Medicaid fee-for-service rate schedules are supposed to be updated sometime in the next 2 weeks or by October 1st. And the rates for skilled nursing, federally qualified health centers, and rural health clinics become effective on October 1st. And then January 1, 2023, a couple things that's a date to trigger for. All the managed care plans must certify to ACA that all provider contracts have been amended. So, if you're home health or if you're billing one of these managed Medicaid managed care plans, they don't have to certify to ACA that all the provider contracts have been updated until January 1. And this new civil litigation cause of action becomes effective on January 1 as well.
Right, and quickly remember also, even though managed care plans don't have to certify to January 1, their rates have to be effective to October 1. So that's, that's something to keep in mind, but you do want to stay on top of that, make sure they're in compliance.
Absolutely. All right. So we do have a number of questions, and so we're going to get to as many of these as we can. For those that we can't, we may not be able to get to everyone's questions, but we will do our best to answer them after the webinar and circulate responses after to the group. So so Susan, the first question here is, and we've talked about this a little bit, is can you address who is required to be at $15 an hour for continuing care retirement communities who share non-direct workers such as cooks, housekeepers, security, etc., between different levels of care such as assisted living and or independent living?
Right, I think we did touch on that, and in that if they are not providing direct care, but they're shared across the continuum of that retirement community from independent living to nursing home. That's a really good question. I mean, because now you're looking at folks that are going from one place to the next to the next. So for the independent, they're not being billed to Medicare, so they don't have to be at $15 an hour. Let's say that person shifts over to the nursing home, they have to be $15 an hour. This is where it's important to have codes and really line the business codes so that your payroll shows that they worked this amount of time in the nursing home or skilled nursing facility, and that their rate of pay was $15 an hour while they were there. And then when they're in the ALF or continuing or the independent side, and they're a cook or they're a housekeeper, they don't have to have that rate of pay there. The reality is that they're going to want that same rate of pay across the board. So you're going to have to determine whether that is financially feasible for you, and also be transparent with the employee that when you're working on these other sides, that you're going to get this rate of pay you're currently getting. When you're working for the nursing home, skilled or non-skilled, you're going to be paid $15 an hour. So you're really going to have a, not just one payroll that shows that. You could, but you're going to have to really keep records on they were paid the $15 an hour when they worked in the nursing home. And that clearly shows when they didn't, and they're a cook, that they were paid, let's say, $11 an hour as a cook for the independent side or for the ALF. So it's really about record keeping. And it's about keeping a distinct line between those three types of providers, if you will, or entities, and where that employee is working. It's different than when you've got, let's say you've got an employee that, like we talked about before, that especially in home health, where they work the administrative side, and then they also do caregiver. You're really going to, administratively, you're looking at, they're going to be at $15 an hour because they're not exclusively doing administrative, they're doing a mix, and they're under one entity. So often when we see the continuing care retirement, they're actually, there's like different entities under one umbrella. So you might have the parent company, and then you have 3 subsidiaries of the parent company. That would make it easy, and it still can be continuing. That would make it easier because you've got 3 different tax ID numbers and so on for paying employees. And then you're not mixing them within one entity type or provider type.
Excellent. So we actually have a number of questions here. So I think, but Nancy, I know that we are approaching. It is 12:59, so we are right on time. So rather than, so we won't be able to get to everybody's questions. We will look at all these questions. We will, Susan and I will get together and kind of provide some follow-up responses, and they will be circulated as part of our follow-up package in the next couple of days here. I want to say thank you to everybody that attended. I hope you found it interesting. Thank you for joining Susan and I. Susan, any final comments or words?
You know, it's challenging times, and again, transparency with your employees and communication within your associations, and keeping records that you can use as, you know, as evidence that this act, while it was meant to increase the healthcare workforce, is really becoming burdensome on the providers.
Excellent. Thanks, everybody. Nancy, I'll turn it back over to you.
Yes, thank you, Susan and Andrew. We did get a lot of questions, and I'm still getting more right now. But everyone, within 48 hours, you can expect a link to the recording and the slide deck so that you can go back and kind of get a refresh of all this information. And like Andrew said, we'll send a kind of a Q&A of all these questions that we received, Andrew and Susan's answers. Feel free to contact them. Also, if you just have other questions directly related to your case, or if you want additional guidance, we're all here and happy to help you. Don't forget that immediately following this webinar, you'll be prompted to complete a short survey. We'd love to get all your feedback on our presentation and anything else you'd like to share with us. But thank you again for joining. Have a great rest of your day.
Thanks, everybody.
Thank you.